Hello, everyone, and welcome to Metamorphosis Medcast, a DMC Club UK production where we explore meaningful transition in medical career. We also celebrate resilience, spotlight journeys that inspire us. And today's episode is titled The Broken Bone Ladder Climbing into Trauma and Orthopedic Training. We are diving deep into one of the most competitive and technically most demanding specialties in UK, which is trauma and orthopedics. I'm your host, Dr. Munira Islam. I'm from K71, and I'm thrilled to welcome our distinguished guest here. We have two guests with us today. One is Mr. Saeef Haque, who is a stay for trauma and orthopedics on the Percivall Pott Rotation in Northeast London Deanery, which proves that you can survive MRCS and still smile. And with us, our next guest is Mr. Noor Mohammad, a ST3 in Trauma and Orthopaedics in North Yorkshire, who's been busy fixing bones and breaking down barriers into trauma orthopedic training. So we won't get any more late. Grab your scrubs, your stethoscope, and maybe a cup of strong coffee to withstand the orthopedic lifestyle, because we are about to get hands on with all the bones, bolts, and break thoughts. So, should we start with Noor Bhaiya?
Yes.
Okay, Bhaiya. Could you start by telling us a little bit about your background and what first drew you to a career into trauma and orthopedics briefly, please?
First of all, thank you. It's a great introduction, which is good. And apologies to everyone for being a bit late. So in terms of trauma and orthopedics, I've never thought I would do trauma and orthopedics until 2021. I graduated in 2016 from Armed Forces Medical College, finished my internship in 2017, got my MRCS done in 2018, well as home, and then came to UK in 2019. Then I did a couple of years of rotating SHO jobs into hospitals. And then I decided, like when I did my first rotation in trauma and orthopedics in 2021, and I really liked it and decided to pursue a career in orthopedics. And then did a couple of years of postgrad rate job, including in a major trauma center. And obviously been trying to get my portfolio sorted and applied a couple of times and got number this year.
Congratulations.
Thank you. Thank you.
Yeah. We have another guest with us, is Mr. Saeef Haque. Saeef Bhaiya. Saeef Bhaiya, you are with us?
Hi. Yeah. Sorry, can you hear me, Munira?
Yes, I can hear you, Bhaiya. Could you please tell us a bit background and what first drew you to the career in the trauma and orthopedics briefly, please?
100%. First of all, thank you for giving me this opportunity, Munira, Atik Bhai, and everyone. It's a great honor to be speaking here. I've, similar to Noor, came from Bangladesh, did my undergrad 2015, came here after doing 6 months of honorary in Dhaka Medical, obviously, and then had no interest in orthopedics starting off, wanted to do general surgery, came here, did a 2 years rotational job in general surgery, vascular, and orthopedic, where I think I fell in love with the specialty and the people and the mentors, and never looked back. Did similar to Noor, I did a trust grade red job in a major trauma center, and then got my number last year for ST4 in London at the moment, living the dream.
Yeah, absolutely, no doubt. So I will do some open questions, Saib Bhai and Noor Bhai, for both of you. You are both welcome to answer whatever you feel, or add to one questions to add to answers to for another one. So my next question will be, as an IMG, because we all are IMG entering into the NHS, what were the earliest challenges you faced, like both clinically or if I say culturally, and after facing them, how did you navigate them through your career pathway, or yeah, what else you have taken care of, the challenges to take care of? Yeah.
No, do you wanna take it on first? I can
Yeah,
add.
can go. So the clinical wise, obviously, is a totally different system, different country, which is understandable, because if you go like even in Bangladesh from one medical college to another hospital, you'll see a lot of differences between how people treat. So it's no wonder like you are moving in a different country and then you will see a lot of different things, which is common. But the main thing was to in terms of clinically, the patient we treat here is more like with the combined decision with the patient. Back home, you mostly treat like whatever we think best for the patient we do, but here we kind of discuss options, and patient also come in place in terms of decision making. So initially, you know, a lot of the things are kind of, I was not sure what I'm doing and how things can be done. So to overcome those challenges, obviously you have to give a bit of time. It's the only thing you have to do. You have to be patient because it's difficult initially. So more time goes, you learn it bit by bit from the ward, from your clinic, from on call. Then you find people around you who is going to help you most of the cases, and then you learn from them. So I would say the main key thing is to be a bit patient. Every individual are different. Some people take very quickly, they can pick up very quickly. Some people take a bit long. I had a bit of, you know, rough start when I came in, but alhamdulillah, eventually got there because, you know, as I said, patience, find people around you who can help you, and then try your best to be, you know, in place. So yeah, that's it. So
Also, the team matters, I guess, like the team members.
Yeah, 100%. So so in my own story, like say for example, I started in Nottingham, so I was finding it a bit difficult to find my own ground there. There are a couple of reasons. Obviously, I was started in a very junior rota, and then COVID started, so I had to go through a different specialty, so not in surgical anymore. So obviously, Saeef, known Saeef from Dhaka Medical College, we both did honorary medical officer there. So he was working in London at that time, and then he said, just come to my place. So he spoke to one of his consultant and eventually got interviewed and get a job. So that's good. Like I had Saeef by as my mentor, friend, whatever you can say, everything. We all worked together, and then we had the same dream, and then we shared our work and everything. So that helped a lot. And the consultants, the other team members, the trainees, they're all very helpful. That's why it worked well overall. So your team is very important, who can support you.
Sabia, I'm also in the same pathway. So can you call me as well so that I can join the team?
Yes.
And live your dream. Yeah, you want to add something else? Yeah, go ahead. Sabia.
I would second everything that Noor has said so far. My personal difficulties were the place. It can get lonely sometimes. Winter, forgetting all of that. Language barrier, initially we have that. But if you meet the correct people, if you have the good mentors, and if you have a passion for something, I think it will take you far. But the most important thing was my 111. You know, in England, if you call emergency, that's 111. My 111 was Noor. So my MRCS part A, part B, I passed with Noor's knowledge. And then obviously we started working together, orthopedics, registrars, SHOs together, registrars together, and now trainees together. So hopefully soon to be CCTs and consultants together, inshallah. So I think as an IMG, find a good mentor. Number one, obviously, find a good friend who has the same goals as you. I think that's really important. I felt that was life changing for me, finding Noor. My mom says that as well. And then, yeah, I mean, if you have the passion, if you have the right people, you should be fine, inshallah.
Thank you, Pep. The next question will be that many AMGs describe this period of adjustment when they are in NHS. So, you know, we have many difficulties like rota patterns. We need to document everything here. Team dynamics can change anytime, especially if we are in surgery, because the patient turnover is very, very high here. So, what were the steepest learning curves for you and like both of you? And when you first began working here, can you describe briefly, like, what was the learning curves which take you here in this point now?
I'll take that note. So I think there's a lot of learning here. First thing is a different system, like Noor said. So don't think because you've come from you've done like 3 years of general surgery, or you've done 5 years of medicine, you know everything. You might know the knowledge, but application of the knowledge and integrating it with a system which is completely different to how we treat patients in Bangladesh, you need to respect that. You need to be starting mentally, I don't know anything. You need to be humble, you need to look down, and you need to ask people. Don't do anything, oh, I know how to do a cannula. Ask someone, if this is how I do it, is this how you do it? It'll make your life easier, and it will make you look much more competent. He knows it. He's just asking me because he's new.
Yeah.
I also felt that as an IMG working here, making friendships with nurses on the wards as a junior doctor was a game changer for me. Having the nurses on your side means that even though, like, if you want to be an orthopedic surgeon or a general surgeon, or any surgical specialty, you want to get into theatres. But as an SHO, it's very difficult. However, if you have nurses on your side and you do your job correctly, you can say, I'll be back in half an hour, I'll be back in 1 hour, I'm going to scrub into theatres quickly and give me a shot if you need me. Having that level of comfort with the nurse, with your colleagues, is something you need to build on. That's your personality. You need to be open, you need to be friendly, you need to be more open to any sort of progressive feedbacks you get from colleagues. So I think that was very important. These are the things that I really honed on, I picked up on. And then, like I said, I talked about mentorship. In terms of skills that I picked up, I didn't know a lot of things. Like, I don't think I did a femoral stab by myself when I was back in Bangladesh. Coming here, I've learned that I asked stuff from colleagues which are not competent. Doing any trauma calls as your primary survey, I've never done that in Bangladesh. Doing that day in and day out in general surgery was breathtaking. Initially was quite daunting, but I learned. Initially I said, I'm new, please bear with me. You need to say that you're new. People will bear with you, people will expect a little less. If you say, oh, I'm the best, then they're like, oh fine, let's see what you can do. So be humble.
Yeah.
Humbleness will get you a long way, and ask for help whenever you need to. And the rest, I think, will fall into place. Noor, what do you think, boss?
I'm going to say the same thing. So I just want to, if we again say from our personal experience, we both never did anything back home in terms of orthopedics. This is just did like two weeks of internship, nothing else. I've never thought I would do orthopedics. We both got registered job after like 10, 11 months of SHO when we did SHO. And that at that point, we didn't know like a lot of orthopedics. We didn't know operate like most of the cases. The main reason the consultants or like the team gave us the job because we were kind of, you know, trustworthy. We worked hard. They know we want to be in the specialty. We tried to we tried to be around with the consultant, ask questions. How can I do this? How can I do that? So you need to open up with people around you, and you need to tell them, this is what I want to do. Can you tell me how can I achieve this? Or you can just get a like small plan and then talk to different people. And then this is how they will guide you. And other than that, like you won't be there. So the consultant who told us like, go on, like we were doing fine in terms of SHO because we had like 2-3 years of experience at that time. And he said, you won't grow anymore being an SHO, step up, be on this difficult place, try to learn from others, then this is how you grow. So I think, you know, being a proactive mindset, and if you have people around you who can support, you just need to get in there. So yeah, this is kind of the way we came across.
Yeah, I can totally relate to that. Like being starting my NHS career in trauma and ortho, the one thing I have learned throughout this 1.5 year, that you need to be humble. You need to ask people, because there are a lot of people who will help you anytime if you ask only. And yeah, we have guidelines. Go through that. Ask anyone. Like there are multiple people who start with you as well. They are also new. So be with them, be around them, do some extra work if you need it, but yeah, try to learn first and then apply that.
Like, so for example, if you ask
Yeah,
10 people, at
yeah,
least 2, 3, 4 people will help you. If you
sure,
don't
yeah,
ask anyone, you will not get any help. So that's the
true,
bottom line. If you
yeah,
think, oh, what are they gonna think if I ask this stupid question, this and that? It
yeah,
doesn't matter. Nobody would remember. Nobody would bother. Like, or like 2 or 3 people say, oh no, I don't want to help you, or like
yeah,
polite way. But most of the people are very helpful everywhere,
totally agreed,
everywhere.
totally agreed,
So
yeah.
that you just need to be proactive in that sense.
Yeah. I know you both started like ST3, ST4 career, but it is a long pathway. So some people start from F1, F2s. So if whoever are not familiar with the structure pathway, could you walk us through the exact NHS training route, like to the trauma and orthopedics from F1, F2 to all the way to ST3, or if I say ST8 to be a consultant?
All right. So if you graduate from here, so you do F1 and F2 after your medical school, so which is equivalent to our internship. And then you get the clearance from your foundation, and then you have to go through a new interview for core surgical training, which is for 2 years, and you have different theme of core surgical training. Like you can be ortho themed or plastic, whoever wants to do. So if you want to do ortho, you would choose like the ortho themed CST. And then when you finish your CST on your core training year 2, you'll apply for your specialty training, which is SC3. And then when you have your portfolio score, you'll be selected. If you cross your portfolio number, then you will be selected for an interview, which is happens around March or April every year. The process starts in October, November, and then interviews around March or April. And then depending on our interview, if you get selected, then you will get a job depending on your rank, wherever your preference are, you'll get a job. And then you start as an ST3 in a specialty training. Then you are fully in trauma and orthopedics. This is 6 years training, so ST3 to ST8. And by the end of it, you finish your exit exam, FRCS, and all other numbers, all the criteria. When you finish, you will be awarded CCT. And then you can register yourself as a GMC specialist registrar to be ready to be a consultant. Most of the cases, even you offer a CCT, people who want to their subspecialty like hip arthroplasty or trauma or spine, they do 1 or 2 years of fellowship, either here in the UK or abroad, before becoming a consultant, full-time consultant. This is how. So it's a long journey. It takes like 10, 12 years roughly. But it depends on how quick you can get into the training job. That's important. For IMG like us, if you can't get your core training done, you have option like to complete alternate pathway. So if you do like 2 years of different subspecialty SHO job, then you can get the crest form signed, higher specialty crest form signed, and apply for orthopedic training number, which we both did. We didn't do CCT, we did alternate pathway and got the number. And then again, you start from ST3.
Yeah, if I want to add, because I'm on the same pathway, so I am also an IMG, and I don't have like the experience of surgery back home. So after internship, I did some SHO job for 6 months and come back here. But the thing is, if you do surgical training back home, even more than 18 months, then you can't apply for CCT, which is the core training, the ST1. So if you're planning to go for surgery, make sure that you are not experienced more than 18 months if you want to start from the beginning. But as Nurha already mentioned, if you have already gained the experience of 18 months, you can go directly to the ST3, but then you need to build your portfolio. You need to mark, tick all the box and then be selected for the interview for the ST3, which is a register post. So yeah, whatever you choose wisely, because everyone is on the same pathway, and I have heard so many of them are not get selected in the ST1 or CT1, whatever you said, because of the experience they gained back home. So make sure that you didn't cross the 18 months timetable.
I'll just add one thing.
Yeah.
Whoever planning to get into a training job in any surgical specialty, the main guideline would be your self-assessment guidance. You can find it the official
Google.
website, either Oriel or the specialty website. Download it, this is your guide, and then this is will guide you what to do, what to do, what to do. So get all the things done, and then you'll be ready to apply.
Yeah, it is called Crest Form. You can search it in Google
No,
even.
not the Crest Form. Crest Form is for to get
Training.
is one of the criteria to apply. What
Yeah.
I'm saying is, say for example, the year of experience you have, how many
Yeah.
operation you have done, how many audits you have done. So this is the main thing you need to work on, and then build your portfolio.
Thank you, Maya. It was very helpful. If we move forward, MGs often struggle to secure UK references. We have already mentioned quite a few times the word portfolio, which consists of so many things like mainly references, some other QIP projects, audits, leadership roles, and they just don't expect us to be a doctor. They want more from us. So, how did we strategically build a competitive portfolio while working in, other jobs, like not in surgery mainly, so other SHO things? So, how did you build your portfolio, doing all the other box ticked audits, QIP projects, leadership roles, everything?
So let me start answering that. So what I did initially was when I came in, I had no clue about training, by the way, Munira. I had a registrar telling me you can apply for training. I was like, oh, is it? Okay, fine. So then I looked up what exactly I need for core surgical training, looked up audits, looked up just stuff like research, looked up stuff like presentation, and then I sat down with local graduates who know obviously a bit more about all of these than me, and I understood what they do and how they go about this. Then I got into the game and I understood what I need to do. Obviously, during the whole process, I had people guiding me. So I had registrars, had consultants guiding me, and I came up with projects, asked them if they had any projects, approached them, and they gave me the projects, and I worked diligently. There have been nights where I worked like till 4 a.m. collecting data on audits. So I don't want to remember them, but they have been nice. So slowly, I got the hang of doing an audit. Once I got the hang of doing one audit, once you've done one or two, you get very confident. But for the first one or the second one, you need guidance, and you need either someone who's done it or someone who's keen to show you how to do it. Definitely. In terms of publications, I mean, I wouldn't say I'm the best in terms of publications, but whatever publications I've got, I got it again because I learned again, went to a consultant, said I'm interested in doing a publication. He gave me a project. He said, a registrar will guide you. The registrar guided me, and then I went about learning in the job how to do it. Time management is always going to be an issue because NHS is busy. You need to take time out of your own pocket, your own life, and try and do it, remembering at the end that this is only something you're doing for yourself. That's for audits, that's for research. Presentations, there's 2-3 ways of going about presentations. So you can present, there's loads of local conferences that happen within UK. You can present in them. Also, you can go abroad because UK technically is local for you and abroad is international. So you can go to international conferences abroad and present there as well if you want a holiday included as well. During my time, COVID was going on pretty mad. So I got to present in a lot of presentations which were online. So I just sat at home, presented something, and got a certificate for it. There was a point you mentioned about leadership. So in any surgical specialty, like Munira was mentioning, it is very important that you're all-rounder, quick bowler, batter, and a fielder rather than just bowling. So you need to be an all-rounder, and so that they judge you on leadership as well. I think everyone in Bangladesh has done some leadership roles, but we just don't know it. Haven't got a proof of certificate for it. So I, for example, was involved in playing football for my medical college. I represented my medical college in many tournaments, played in DMC as well, which I lost. And then I was also acting secretary of my sports club. I never got anything from it, but once I understood that this is something I need to get a letter from, I asked my college to provide me a letter on a letterhead to say I did this from this year to this year. And that exactly matched the portfolio requirements for leadership. Coming into the country, I then took up roles to teach juniors, like I set up a plastering course for juniors, for SHOs like myself, for F1s, F2s, under the supervision of my consultant. And then I set up like all these plastering courses where people were teaching, I was supervising. I was literally leading from the front, making sure you have enough plasters, making sure you have enough patients to plaster on and all of that. and you could also get leadership certificates from that. This is what I'll pause there. I'll give Noor a chance to speak.
Yes, Noor Bhaiya.
Yes, exactly. As I said, I almost copied Mr. Saeef by whatever he did. But just I want to mention a few things like, so you have to have a plan, because these are the things is not gonna get done like 1 or 2 days. So it's some of the projects takes very, very long time. Some of them like short time. And also the role, sometimes you have done something you don't know, as Saeef mentioned. So you need to think about when you are going to apply for your number or like training interview or whatever. And then you need to find what you have and what you can achieve in next like 6 months. Say, for example, you have 6 months time, and then you want to apply after that. Don't get involved in a project which is going to be published after 10 years or like 5 years, and you're wasting time.
Yeah.
Rather try and find out things are quick and you get it signed. Initially, when you're applying, you don't have to have a like high impact journal publication or like big audit on your name. What you need is things are done, you have presented in acceptable conference or seminar, and then you just do them. So here, most of the, so you need to find out where you are in terms of your the portfolio scoring, and then you need to think about, you cannot get involved all of them together, like all 10 domains, you cannot get involved. So try and find out which are the quick one, you can get it done, and this is done, and then you move on to the next one. So this is very important to find out, like where are you at the moment, and how can I finish this tick box, this box, this box. So the good things are like to start with small audits or QIPs. Then you can publish audit and QIPs as well if you can sometimes. And then the leadership role, Saeef mentioned, there are many leadership role around. Like I had like few local from Bangladesh.
Yeah.
And when I came here, I did some, as like Saeef as well, plastering, all those things as a local. But I got involved in Bangladesh Conference UK last year after speaking to Tanvir Rai. And that gave me like highest point as a like national organization or leadership role. So there are many opportunities around. So you just need to find it and get involved. So yes, so the understanding that the timeline is gonna take and get it done, rather than involving in everything, not having done one is problem. Rather than you involve like few, get it done and move on to the next one. Because the first game is to finish your like get your evidences ready to apply, then you can prepare for your interview. So I would say like this is one of the things you need to keep in mind. The other thing is the people are already here. Sometimes you think, oh, how can I do an audit? How can I do a research? I've never done. So if you think and that you're not started, nobody will come here and like feed you here. You just need to get involved, and then you learn on the process. And then next one, you will be more sleek and more quicker. So this is how you do it. So try and find out like time slot and small project. If not, now you have ChatGPT, just ask them to give you ideas. I want to do an audit by leaks. What are this? Give me some structure, and then you can work on it.
Yeah. Thank you so much. You both answered my next question, like half of it, which I'm going to ask you now, which is like, we have talked about the IMGs who are at home, but some people already are entered into the NHS system, like me. And I'm working here for more than 12 months now. So during our NHS orthopedics or whatever surgery specialty we are in, how can we maximize our chances to enter into CST or direct ST3? Like if we miss the period of CST applying, then how can we maximize our chances to enter in directly into ST3 place?
So if you think you're not going to be eligible anymore for core
CST.
training, then you just think that I'm going to apply for registrar job next year, not like after 3 years. So you have to think about, I'll apply for next year, and you have to apply for next year, because applying for job is free. Because the moment you apply, you'll know what are the things you need to submit. Even though if you're not ready, you'll find things that you have to do for the next year. So that's the number one project for you. So you apply, number one. Number two, so before that, sorry, you have to clear your MRCS. Obviously, this is one of the mandatory thing for going to the higher specialty training. So you have to clear your MRCS, both Part A and Part B, get it out of the way, and then you focus on your portfolio building. You can do a little bit here and there while you're doing your MRCS as well. But the main thing is get your MRCS done and think next year I'm going to apply, and what are the achievable small goals you can do before you apply next year. So if we talk about trauma and orthopedics, so I can share a link where you'll have the page that these are the domains you'll be scoring on your portfolio. So the most score you'll get from orthopedic experience, which needs to be between 10 to 42 months. So you have to be very careful you don't cross that. You need to be in this period like 10 months to 42 months. The other areas like getting your neck of femur fracture number, like 18 or more, you can get it done while you're in SHO. As I mentioned before, you need to have a good team like with the word, and also finding another SHO who wants to do it. Then you can split, like one day you can ask them, oh, you stay on the word, I'll go in theater, and then ask them another day, they can go into theater and you can stay. So this is how you have to get your number done. The primarily your neck of femur fracture number, which is gonna be counted in your portfolio, and then getting things like audit, presentation, leadership, and teaching. So these are the things you can start with at the beginning, and then slowly you can build on. So the bottom line is you need to think, I'm going to apply next year if you're not ready for, if you already passed the timeline for core training.
Thanks. Saeef, you want to add anything else?
Saeef is on call as well, so he might.
All right, yeah, we can move on then. We all know the ST3, the higher specialty training portfolio, is very notoriously competitive, and you have already mentioned that you need to apply. So we need to apply first to know what the domains are we need to cover. So can you just briefly tell us about the main domains, like break down the domains a bit and explain it, like what truly differentiates a strong applicant from a weak applicant? Like if you apply and you got rejected, what are the differences that it makes a strong, like it differentiate the strong opponent from the weak one?
So number one, getting a interview is one thing, and then after when you selected for interview, then it will comes, are you a strong candidate or weak candidate in terms of your portfolio. So the when you see the criteria, there'll be 12 domain at the moment. They changes a little bit every year. So the last year they added, previously it was 11, 10, now it's gone like up to 12. When you see it, you'll see every section is self-explanatory. They explain very well, but there are the key things people might not understand initially. So the number one question is, how much experience do you have since your post-foundation? So it's kind of months, 0 to 39 months, 40 to 51 months, and then you'll get an N number. Okay, so say for example, you have more experience, 7 or 8 years of experience, and then your N will be very high. So say for example, your N is 5. So you are a little bit in the, red side. Because there are few domain, those points will be divided by your N, such as your research, your audit, your presentation. So for an example, if your N is 3 and you have done one audit for which you'll get 1 point, your final point will be divided by 1 divided by 3, which is 0.33. You get it?
Yeah.
So this is applicable only for presentation, audit, and research.
Okay.
Rest of the things are not going to be divided by your N number, such as your orthopedic experience, Your other specialty experience, you'll get 2 points maximum if you work 4 months in different specialties such as general surgery, ITU, or vascular, plastic, whatever you do is written there. What are the specialty you can do? So you get 2 points from there. Your logbook, which is neck of femur fracture numbers, you don't have to do skin to skin all of them. You can't, because an SHO is not possible. So if you do part of it or like most of it, then you can log in your logbook as an STS, supervised scrubbed, and then one of the consultant will sign you off after some point. So you'll get 4 marks from there. And then you can score on your teaching, maximum 2. You can score leadership, maximum 2. You can score your, what else do you have? Post-graduation degree, if you have any master's, PhD, all those things, maximum 2. So when you look at this, the whole thing, so you will find out there are few things are very quick to achieve, and then there are few things like will be difficult, like getting a postgrad degree is not so easy. Getting 10 publication is not so easy. So you know, I focused on like the project I would be able to achieve. So this is very important. The key things to remember, you don't go your orthopedic experience more than 42 months where your score will be less, like 4 points will be deducted, which is huge, because the total number is 32 or 34. This now is 34. And then last year, they don't publish like what is the last cut-off score, but you get a little bit of idea from surroundings. So it was around 20 or 21 last year, so which is increased from 16 to 20 before this year. So it's become so competitive in last couple of years. So without doing like big project, it is achievable to get an interview. So if you focus on the things are achievable within a year or 2, you just focus on them, and alongside you can do other projects as well.
Thank you for the encouragement. You already mentioned about logbooks. So I know there are some different operative logbook, like one of the training logbook. There is non-training logbook as well. Like what logbook or requirements, or you already mentioned NOF numbers we need to target as an IMG during our CST training to get into ST3.
So if you're solely focusing on your interview, then it is your NOF number, which is, they mentioned clearly, you have to have 18 or more as an STS. STS means supervised scrubbed, supervised training scrub. So basically you do under supervision. So you're not expected to perform any case by yourself as an SHO. So that's the primary thing. But for your own growth and learning and to become a surgeon, so you can target small cases like simple ankle fracture, simple distal radius fracture, the knee scopes. Like if you can go to elective as well, do carpal tunnel decompression. So these are the operation you can get to do like at the beginning, and more you grow, more you learn, you get more opportunities. So one thing I know one of my friend who used to be always around the theater, obviously not during his job. When you finish your job, go around the theater, speak to people like registrars, consultant, then they will, when they see like you're interested, you are coming despite not having any chance, you go on second, third time, they will oblige to be, give you some chances. Because when I see, like for myself as well, someone is coming regularly, you'll definitely give them chance to do things. So try your best to go to theater as much as possible, but not, some people, they leave the word, but not telling you. So it will come back to you as a feedback that this is not good. I wouldn't suggest like be on the theater, ignoring your ward job, ignoring on call, all those things, because what you need initially, your numbers and just showing that you're interested. Sometimes you might need to sit at the bedside If you're really struggling with the numbers and your interview is coming up, you might need to go during weekend on your off time. If you see any neck of human fracture happening, you just get and scrubbed. Like you might see one or two, and then they'll let you start to do things, and then more you do, you more get to do more. Like the whole case you can do as well.
Yeah. Thank you, Pam. You already mentioned MRCS is the stepping stone because if we need to apply for ST3, we need to complete the MRCS. So it always remains as a major milestone. So you have done your MRCS and also with Saeef Bhaiya. What revision strategies worked for you, especially balancing preparation and your rotation in different surgical, theater and ward jobs? It is a heavy department, we all know, like any surgical department is a heavy one. So what strategies you applied before your exam?
So I'll
So
give it to Mr. Saeef Bhai, because I did my MRCS back home. So Saeef Bhai did
Oh,
his.
okay.
that's all right. So I think from my point of view, what I did was firstly I was intimidated by the fact that I have to give an exam while working in the hospital and also doing household chores, which is a lot, believe me. Um, and then, so how I managed time, firstly, I took help from people who've given the exam recently, which was obviously, again, going back to Noor Mohammad. He was like, this is what I did, this is what you can do. I was fine. So how I started was I used question bank. So I personally used EMRCS
Mhm.
at my time, and I went through the whole of the EMRCS twice before sitting for the exam. Okay. Personally, other things I did was I had a gallery in my phone, a gallery folder which was only anatomy that was relevant to the exam.
Okay.
So tendons, nerves, anything that normally comes in the exam that I figured, I would just take pictures of that and keep on going through those mnemonics and stuff every morning after waking up, at night before going to sleep. That gallery was what I used to do at that time instead of watching reels, which I do now. Okay. That was very helpful. Every day before coming home, I used to do 1 hour of reading in the library, just go through a couple of questions, and then after coming home, do all my household work, and before going to sleep, do a couple of questions as well. When I say couple, I mean at least 30, 40. Have that number set, how many you're going to do each day. Then in your head, you're going to be like, okay, I've done this for my day. I've done well. Also ask for help from people who recently passed because they know what they've done and what they could have done better, so they can guide you. So never shy away from that. That's my, and again, also in between wards, when I was having a quiet ward day in general surgery and orthopedics, I used to sit on the in front of the computer and just go through my questions, just see. And what I used to do is a question that I saw, I did not get the answer right. I would see the answer at the bottom, see the explanation, and then Google up what's happening. Why is this not? Noor also asked me to read a book called Raftery for MRCS Part 1. So I read that as well, through and through, for pathology, for physiology, and for anatomy as well, which I think was key. Knitter is your best friend. You need to have Knitter at some point around you. Have the pictures on your phone or somewhere, but you need to have them, like I said. That's me, part 1. Part B is, if you're already in the UK, it's a bit different than being back home. If you're already in the UK, your communication skill is already going to be a bit more like the UK grads or a bit towards the exam oriented. So what I did was, again, have a group, practice with people. You need to practice, 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 because part B is communication and knowledge. So knowledge you'll get from reading, which you will get people send you materials. You can use, again, you can go to courses. There's several courses available now. I'm not going to take names because I'm not affiliated with anyone, so I'm not going to take names. But there are several courses available in the market now you can do. But you need a partner. MRCS partner. I personally feel you need a partner. You need someone who you practice with regularly, and then you recite stuff which you are expected to say on the day of the exam as well. I think that is key aspect. Also, again, like I said, speak to people who have recently taken the exam, what they have done wrong, why have they failed, what they could have done better, which I think would, again, change their thinking. That's me personally. Noor?
So for part A, I think the key thing to understand, like you have to pass separately. Like there's 2 papers, right? Paper 1 and paper 2. So paper 1 is basic science and paper 2 is all the surgical specialties. In paper 1, I would highly recommend to target anatomy, because anatomy is your friend. You can score full mark in anatomy, 75 out of 75, if you read properly and if you use materials properly, because these are the questions will never get changed because you can't change anatomy, right? So it will be the same questions or like same type of questions every year. So you just need to know all the topics that can come in MRCS. So the same resources EMRCS I used, previous year questions are recalls, and I added from somewhere else is like whatever I find, just added on top of that. One thing I used to do in Netter, say for example, you have a question, you have to go and see in the Netter to understand it. So at that point, I would write that question on next to the Netter book, like where I went to see it. You know what I mean? So if you do it every time, you'll see your Netter will be either lots of questions written there, and then you can quickly go through them, like for paper one. So they're like at the end of like few months, you'll see the your Netter is full of questions of MRCS, and then you can just quickly go through, and then that will, visualization as well. So this is one tip I can give. And paper two is a bit difficult in terms of it's huge, like all the surgical specialty are included in a paper two. So I would say stick to one particular question bank and add your knowledge from different places like Googling or seeing some other places, because you can't finish all of them by yourself, never ever. So just stick to one, whichever you think important, and then add recall question, add this and that from somewhere else, like additionals. So this paper two is a bit different, but paper one you can target anatomy, and then that will help you to pass. In part two, as I said, I did in Malaysia, so it's a bit different. If who is taking exams from Bangladesh, they can do, it's difficult to understand actually what happens. You can't imagine, like, say, for example, a communication scenario reading, but now we know what's happening here, right? So you can't imagine that, but you have to practice, like, from people who have done recently, or if you have chance to have friend who is working here, practice with them, because they will know bits and pieces in terms of communication. So that will help.
Yeah. Writing question. I will add it here that writing question to the Netter was very out of the box and very lovely tip. Thank you, Bear, for that. So we run through everything possible we can do for our application. So from everything CST and ST3, we run through all of them, but still we are not up to the point where we are selected. We apply, we did our best, but there are some pitfalls for especially IMGs during the interview preparation. I'm not sure what lacks there, but during our interview preparation or the interview day itself, we are not on our best. Can you mention, like, what are the common pitfalls like you noticed among us or IMGs?
So by the time you will get selected, obviously you will be in a good position, because getting into that position is very good. So you should be proud on yourself. The main important thing, we lack confidence, because interview is a kind of knowledge plus communication. So this is the place where we fear most, because this is not our first language, first of all. Secondly, the attitude during the exam that we used to be in back home, it's good to be humble and submissive. We are a bit too submissive. This is what we are taught, like back home. So sometimes people can think you are not confident if you are in that. So you cannot be overconfident or rude, or you cannot be underconfident. Showing that you're confident what you're saying, this is the most important. I think this is the most difficult part we face, because we have the knowledge, we practice a lot, we know, like, in terms of knowledge, sometimes better than many other people, but we cannot verbalize them like nicely. So this is the practice comes in. Practice with what, like, I've learned from Saeef Bhai. He practiced with almost everyone wherever he can, like consultants. He never shy away, like asking people, can I practice this scenario with you, or can I? So this is what he did. He used to got me into the group, like, Noor, come as well. So I was a bit shy, like I couldn't go, like, most of the time. So this is the thing, like, by the time you see, like, you do practice with different people, and you get a bit of confidence of saying things, structuring your answers in a way that you won't be like here and there, or not in the beginning again and come in the middle. So having a good structure, getting practice, and build your confidence. And you need to think like you got the interview and it's just a matter of 40 minutes.
Yes.
If you can show up confident, your answers are good structure, you'll get a number, because people are getting it. So now I'm in training. I've seen many other IMGs as well. They're in the rotation, including like in this year as well. In my rotation, we are 10 trainees. So we have 4 IMGs, I guess, or 3 IMGs. So it's not impossible thing, but as I said, when you get to the interview, you have to do a lot of practice courses and be with the right people.
All right. Saeef, you want to add anything here?
I think everything Noor said, I agree. In terms of the interview, I think it's a bit of understanding the structure, understanding what you don't have to say, and how to control yourself. So I have a tendency, unlike Noor, to be very outspoken. I talk a lot. If you were to leave me in a bottle, I can talk the whole day for 1 hour. You need to understand how much of your talking is impact for the other person on the phone. So for the interview, that's what you mean. You're telling someone something that needs to make sense in short sentences, not to hold them. Practice-wise, again, I will hold on this forever. Have your partner. Be with someone who's also in the same boat as you, giving the interview, giving the number, has the same passion, and then practice. Loads of question banks. Again, no affiliations with anything, but there's loads of question banks you can use. If anyone wants to message me, DM me, that's completely fine. I'm more than happy to email me, more than happy to answer the questions. But there's loads of question banks you can use. So what me and Noor did, he bought one question bank, I bought one question bank, and then we use each other's login and then practice from there.
Yeah.
What I did differently during this year, but during the year I got a number was I practiced with a lot of consultants. These are people who've been in the interview panel, who've been across both sides of the table. So they've been interviewers and interviewees, and they know exactly what questions they might ask me and how to answer them. And they told me, this is where you're lacking, this is what you need to change. So I think that really helped me hone my skills to the best and get where I am.
Thank you, Bea. As we are already on the interview section, if we go through the MG group event, the most commonly asked question is, what will they ask during our interview? So if you could summarize 3 must-know clinical principles for any kind of trauma and orthopedics interview thing, like we know there is NOF, there is fracture, open fracture management, and there is some other operative prioritization. If you want to summarize 3 must know principles of trauma and ortho before entering into an interview, whatever it is, CST or ST3, what would they be?
So I think from my point of view, first thing I learned was scan, span, and plan. I'll explain that later on, but scan the patient, span the patient, as in reduce your fracture, and then plan accordingly what you can do later on. But this is relevant to a lot of things. So for example, couple of basics is always look at what the problem is. So if you've got a fracture, does it need an operation? Can you deal with it without an operation? Yes, no. Is it just a fracture, or is there a dislocation associated with this? If dislocation, yes, open close. If dislocated, reduce it, repeat scan, and see what you can do after that. These are the basic things I go by. Also, like if I want to talk about particular topics, if that's okay, Munira, particular topics like emergencies in orthopedics, like open practice, you already mentioned, so I'll just hone on that. Open practice in orthopedics. I'm currently working in a major trauma center in London. Open practice is a very common thing. So if you get an open practice, the first thing that comes to your mind is my BOS guideline. There's something called BOS guidelines in the UK, which you need to follow. It talks about stuff like, if there's an open fracture, what do you need to do? First of all, make sure the patient is stable hemodynamics and all of that, ATLS, A2 assessment, make sure this is the only injury they've got. If they've got that, we want to do with that. Then you start off with stuff like antibiotics, tetanus, making sure you, if it's an open fracture, you've reduced it if it's dislocated, making sure you've washed that wound, covered it with a saline soap cloth. Before you cover it, obviously, take a picture of the wound and then apply plaster. 1 second. No, can you take over? That's okay.
No problem.
Mm.
So, like, if you have an interview, like even for Trustgate job or ST3, whatever, I think what they want to see in yourself in different domain again, like they want to see your portfolio, they want to see your clinical knowledge, they want to see how you deal under pressure. So interview is a pressure situation. They will put you in pressure, and then they will see how do you manage your pressure. And then they want to see what's called communication. So these are all things they will look at. And if you see the marking scheme for an interview, they will have a scheme in front of them, and then it will see how you do in each domains. So it's not about you know everything and then you just answered. You know what I mean? So like, say for example, you've memorized all the bullet points or all the topic, and then you just said everything and you're not logical, or they're asking one thing and you're answering other thing. So you need to understand the question first and answer accordingly. What they don't like is being prompted. If you think if you answered everything correctly, but they're asking, okay, what do you do next? What do you do next? Okay, fine. What are you going to do with this? Okay. You feel like they're just asking questions, but they're prompting you. They will mark you down.
Yeah, red flag.
So I say, for example, any interviews, you need to know all the emergencies. I think any surgical specialty, whatever specialty you're going in, you need to know emergencies. Okay. Like in trauma and orthopaedics, particularly, your emergencies are open fracture, compartment syndrome, any infection like neck fascia or joint infection, any fracture related to neurovascular injury. So these are like your and dislocations. So can be shoulder dislocation, hip dislocation, or a tibia fracture with either compartment syndrome or vascular injury or open fracture. So these are your common or pediatric fracture supracondylar. So these are like common emergencies. And you have BOST, something called BOST guideline. You have to look at through the website and find out all the BOST guideline. You need to know all the BOST guideline, not like memorize the 20 points, relevance of every topic you're reading, which you can apply in your answers or your day-to-day life. So understanding the emergency topics and finding a structure to answer them. Like say, for example, if they're asking you, okay, you have a 6-year-old child, fell from monkey bar, painful, swelling elbow, they're coming to ED, how do you assess the patient? Okay, so you're thinking in your mind, this is a supracondylar fracture or some elbow fracture or an elbow injury, or they can put you an x-ray saying, what do you see? So say, for example, you've seen a Gardland 3 supracondylar fracture, very displaced. So you need to answer your in a structured way. You can't say, oh, I can see a supracondylar fracture Gardland 3. No, you would start with, I can see a AP and lateral radiograph of a skeletally mature individual. The most obvious finding, I can see a supracondylar fracture Gardland 3. I would be worried about neurovascular injury in this patient. So I'll go and assess this patient by taking history, thorough clinical examination, and further investigation. So you compartmentalize your answer as well. In history, I want to know this mechanism of injury, any concern for NAI, any past medical history, all those things. And then examination, I want to see the soft tissue, I want to see neurovascular examination, and then you tell them how you do neurovascular examination by checking this, and then I would do further X-ray if needed, and then I would decide my plan. So you're not asking them to interrupt you. If they say, okay, you've done everything, what is next? Then you can go into the management. But unless they're stopping you, you just keep going on to show, and in a thorough, like structured way, history, clinical examination, management, and then they can go up to theater complications. So more you go like complex things, you'll score better. But if you're still in management, initial management, they're asking, oh, are you going to speak to parents, or are you going to do anything else? How do you do neurovascular examination? So if you allow them to question you, then it's bad. So knowing your emergency topics, knowing your portfolio common questions, knowing the scenarios that might ask, and then just prepare and practice like in a logical order. That's very important.
Thank you, Bhaiya, for such an insightful answer. Finally, like we are almost end to this podcast, what message would you like to leave for the medical graduates or early career doctors striving or thriving to climb their own broken bone ladder?
So if someone, so I'll divide my answer, like compartmentalize my answer, right? So
Yeah.
if you're in the UK, will have some goals. If you're outside the UK, want to come here, so you'll have different goals. So who are outside the UK, your first, if you really want to come and decided you are coming here, knowing all the, bad things, good things about the UK training program. So everywhere you will have some advantage, disadvantages, wherever you go. But if you decided you're coming here, your first aim should be you come here as soon as possible. You can't really build your portfolio or your career ahead without coming here. You need to come here, give a bit more time to settle in, and then you will start. Doesn't matter which level are you in Bangladesh or in any other country. The moment you come here, then you understand. So the first thing would be, if you're outside the UK and thinking your career in the UK in orthopedics, you need to come here first and then start on. Those who are already here, as I mentioned before, think about your timeline. Say, for example, you're not going to apply for your CST anymore. You need to think about getting step up as a trusted race job, and you are applying for number the year after and prepare accordingly, because it's not a easy process, but it is achievable by being proactive, getting support from people who need to, and ask people who has done this, or like you'll have trainees around you. Doesn't have to be from Bangladesh or your own people. Just ask any people who are in training program or who is trying to get into the training program in good position, and ask them to give you some tips and suggestions. If you ask 10 people, one at least will help you. At least one person will help you, and that is enough for you.
Thank you, Bhaiya. And that wraps up another podcast of ours. A huge thank you to our lovely guests, Saeef Haque Bhaiya and Noor Mohammad Bhaiya, for sharing their insights and wisdom. Thank you so much. If you guys have been inspired or mildly terrified by what you have heard today, remember, every great surgeon starts somewhere, usually holding to a retractor. If you're F1 or eyeing exclusively for ST3, let this be your reminder that persistence, passion, and maybe a bit of power tool precision will take you there. Until next time, keep learning, keep growing, and keep transforming one episode at a time. This is Munira Islam signing off from Metamorphosis Podcast, where we turn medical training into metamorphosis and maybe just a little bit of madness. Thank you, everyone. Thank you for a lovely time. And again, apologizing for being late. Thank you.
Thank you so much for having us as well. It's a great session.
Thank you, Marina. Thank you, Noor Mohammad. Thank you. It was a great session, guys. Sorry, I have to go in and out. I'm on call as well.
Thanks
Sorry.
so much.
All right.
All the best, everyone.